Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast today. My name is Terry Fletcher, and happy Thanksgiving week. I hope you have lots of amazing recipes planned for Thursday and get to spend the day with family, friends, eating, watching football, maybe participating in a turkey trot 5K. We have that around here. Or maybe a day at the beach. You can tell where I live. But hopefully you have some good plans for this week and maybe get a day off or two. So today is the last Tuesday of the month. And you know what that means. That means that we are at Top 10 Tuesday, or the top 10 coding, billing, and reimbursement and compliance questions that I've received this month. And boy, do I have a few which speak to many specialties. So we want to get that started. There's a couple of them that are a little bit long-winded in the response that I'm going to give. So hopefully you'll appreciate some of the information, and it's some things that have actually been requested. So we like that everybody's kind of put in some requests on some things that you'd like to hear. So hopefully you'll find this information helpful, and away we go. So, but first, today's Codecast is also brought to you by Chicago Area Health Information Technology Association, ilhema.org, and Land Rover USA. Explore the winter wonderlands behind the wheel of a new discovery sport, landroverusa.com. I also wanted to mention before we get started that the Codecast podcast celebrated its second year this month on November 5th, and I can't believe it's been 2 years. So November 2017 is when I started all this. How crazy is that? 110 episodes, 2 years, and different topics every week. So sometimes I have a variance of a previous topic, but not often. So thank you for listening, and remind everybody to forward this along to anybody you think it can help, and hopefully we'll continue to bring out some really good stuff for you. So again, we appreciate everybody who's listening in and the feedback we've been getting. So on to Top 10 Tuesday. So our first question comes today from a Florida client asking about palliative care. And so just wanted to talk about that. Thank you, Pam, by the way. So it says, we have a medical necessity question on palliative care. You know, our physician group is huge. Multiple physicians are treating the patient's symptoms. How do you determine what the palliative team is treating separately or that requires their particular skill? Also, as part of palliative care, can they be checking up on the efficacy of a drug another doctor ordered? So, for example, pain medication. And it appears that one of the goals of palliative care is pain management, but the other doctors continue to manage the pain also. So we're having trouble identifying who gets credit for reimbursement and for how long. Okay, so a little bit long-winded here, but I just wanted to let you know how this works, because a lot of payers are considering palliative care for payment, but they also need to have a little bit of a differentiation, as you suggested in your question, to make sure that they're not double dipping or overpaying, or there's crossover as far as paying for the same service. So first of all, for those of you out there that do not know what palliative care is, it's a form of medical treatment that manages the pain, the symptoms, the side effects of chronic illnesses such as cancer, HIV, CHF, MS, stroke, Alzheimer's, just to name a few. It's important to understand what palliative care is not. It's not hospice care. So in fact, palliative services are very different from hospice care in that you can receive care while still pursuing a cure to improve the quality of life. Now, hospice care may be similar in the care, but it's administered for terminal patients they're in the last months of their life, or what they call end of life stage. So when curative treatment is no longer an option, that's when you're dealing with the hospice care, but you're still trying to cure or relieve the effects of a condition, and basically you're trying to make the patient more comfortable. So just trying to manage how they're dealing with and what they're dealing with. And that's tough sometimes for payers to want to pay for any of that, only because the medical necessity to cure or relieve a condition isn't really there. So in response to your question, how do you deal with medical necessity? And are you going to have many overlapping services? And first of all, yes, you may have some, since there's a medical team required for palliative care to be considered, that definition of it. Usually there's a physician, a mid-level provider, nurse practitioner, and a social worker. Once the patient's palliative care is not improving their quality of life as they're being treated for the chronic conditions, now it's considered more of a therapeutic option and no longer medically necessary. So that's really what you're looking for in the record. And this should be well documented by the practitioner that it's how it is improving their life. Also, each physician or provider involved in the palliative care needs to define their role in the care. So their encounter should clearly state what they're managing, what they are doing to improve life, and since many payers limit visits related to palliative care, it is important to know your contracts and contract limitations. Medicare tends to not allow more than 3 overlapping providers. And can one physician check the efficacy of another physician's prescribed pain medication? The answer is yes, but then that could take away also from the prescribing physician's care reimbursement if they're also falling for the same condition or same diagnosis. So what I would do is educate your physicians to clearly define their roles in the care and make sure it's well documented. It's not your job to go on a fishing expedition and try to figure out who gets what. It's their job clearly define what they should be getting or what they should be reimbursed for within that care scenario. So question 2 comes from the same practice in Florida, but this is a question regarding ACP or Advanced Care Planning. I did a podcast on this back in the, I actually looked to see when it was, so back in the day, and it was actually episode 8 from 12/19/2017. It's amazing how time flies, but if you wanted to go back and check out that entire podcast on that, that's where you'd find it. But all episodes are still available on my website and some platforms. But the question is, the team bills a new or subsequent visit and the ACP visit. It's obvious that the ACP was done, again, advanced care planning, but it is hard to differentiate between the ACP and the actual visit. So how do we support billing the service? Okay, first, I really want to bring this to your attention, and I deal with this with audits a lot of times, and some of my clients that I try to educate on what their role is. Please make sure that your physicians know they're responsible for really carving out what they're doing within the record. You shouldn't have to, again, go on a fishing expedition. So if you can't clearly see it and it just looks like a regular E&M code and a regular E&M service, then don't code for it. So you have to make sure that they understand what they have to fill out, what needs to be in there, what has to be carved out to be able to bill for certain services. So first, many states require advanced directives or a form, they call it a POLTS form, provider orders for life-sustaining treatment. That's an approach in approving the end-of-life care in the United States, and it encourages providers to speak with patients and create specific medical orders to be honored by healthcare workers during a medical crisis. In California, we have something called the MOLTS form, medical orders for life-sustaining treatment or a living will discussion. So they also need to have a durable power of attorney for health care, not just a regular power of attorney. One thing to be careful of, and I found this out when my father passed, is that I had power of attorney over his affairs, but as soon as someone passes away, the power of attorney is no longer viable. You have to have a power of attorney for health care as well. The medical record also has to indicate specific time spent discussing the ACP directives, okay, because this is a time-based code, and you have to have at least 30 minutes face-to-face with the patient and or family to report the 99497 code, and it's worth $85. So you want to make sure that you have that. And remember, the one thing, and I was actually talking about this with somebody the other day, and it'll be actually one of my questions here today. Remember, with CPT, you can round up your time. With Medicare, you can't. So Medicare doesn't allow you to do that. You have to have at least a minimum amount of time. And so make sure you're checking on those. Number 3 says, hi, Terry, I have a question about a procedure note I received where the header, and that's the list of what the doctor wanted to do in the op report, stated that the physician performed a selective bilateral renal angiography, but the report detail only showed an abdominal aortogram and then results reflective of aortic and renal disease. And then a stent and angioplasty was performed of the right renal artery. How do I code for this? I don't think I can code the selective bilateral renal, the 36252, correct? Okay, so you are correct, and it was a good catch on your part. And some coders that do peripheral or non-coronary interventions, they don't always get this. So if the bilateral selective renal angiography was diagnostic and you actually had angiographic data and detail to show that the catheter actually went into, was guided into, negotiated, what they call it, opacified, selectively engaged, anything like that, with an injection made into the renal, into the right renal or the left renal arteries, then you could have coded 36252. But what you saw was an abdominiotogram. We kind of call that a non-selective renal. It means that the catheter stayed in the aorta and the physician injected at the level of the renals. And so they're looking at not only renal information, which is kidney poles that have blood supplies to the kidneys, but also looking at aortic information. And so, when that happens, that's a 75625 code with a 26 modifier if it was performed in the hospital setting or in the facility setting. And you're right, you can't have that catheter placement. But then when the physician also went into performing a stent and an angioplasty, so that code would have been your 37236 code of the right renal. And you also get to capture a catheter placement. So you would have 36245 because that is a below the diaphragm catheter placement, and it does not include imaging because you already got your abdominiotogram with the 75625 code that visualized the renals, but it did not selectively go into the renal arteries. So again, you would have 37236 for your stent angioplasty. You would have 36245 for your catheter placement, and then 75625 with a 26 modifier for your abdominiotogram. Okay, so that was a great question. Number 4, Terry, I have a question from a previous podcast on basing our E&M on time. We are a pediatric practice, and the physicians keep telling us that we should not worry about CMS rules on E&M. But what is the difference in what CMS says versus what AMA CPT says that would affect pediatrics? Okay, so there's a few differences, but I'll just let you know which one affects pediatric. Medicare and CPT do differ when it comes to determining the time for encounters and how to report time, which the physician spends more than half of the visit counseling or coordinating the care of the patient. Both sets of guidelines agree that the documentation must reflect that 50% or more of the entire visit time be spent in counseling and or coordination of care, and that the extent of that counseling must be documented in the medical record. However, AMA CPT allows providers to round up when reporting physicians' time, whereas Medicare does not, according to the Medicare Claims Processing Manual, Chapter 12, Section 30.6.15.1. So, for example, in the CPT manual code description, the typical time for a 99213, that's an established patient level 3 office visit, is 15 minutes, and 10 minutes for the code 99212. So for Medicare patients, CMS, when the physician documents that he or she spent more than 50% of a 13-minute visit with the patient discussing the treatment options, you should report 99212, not 99213. However, for this same encounter, for a non-Medicare patient, CPT guidelines allow providers to round up and report CPT code 99213. Also, CMS recognizes preventative care codes but does not pay for them, so the patient is responsible for the allowable. But most commercial plans allow for an annual well check. So that's what could be reflective of pediatrics. But I get that all the time. I get physicians saying, well, Terry, you audit for Medicare and you're also auditing based on Medicare guidelines. And so we're pediatrics, so you don't understand what we do. I'm like, correction. I am not only certified in evaluation and management coding, but also certified auditor. And also there are very few differences in what Medicare versus CPT says on E&M coding. And when I can give the physician the benefit of those differences, I do. So just know that there's really only two things to be aware of. And one is time, and then one would be the preventative code services. So question number 5 comes from Carolyn, thank you, on corrected claims. So Cigna duplicates and what happens when you send some payers. Okay, so when you have a duplicate claim on corrected claims, so when you send a corrected claim, first of all, make sure that the insurance company has considered the claim first. Okay. And then if you feel like you need to send a corrected claim based on their response to you from what you submitted to them, then you can send a corrected claim or a claim for reconsideration. And there's forms for that as well. Some payers want the refund before they pay out on a corrected claim. Some will pay out on the missing amount, and some will just deny for duplicate if you don't wait to see what they're saying on that first. I actually had a practice that did that. They said that they would send, 2 line items would leave their office, and they found out maybe 3 or 4 days later that there wasn't a 25 modifier attached. So then they would rebill it with a 25 modifier. But now they're getting a duplicate claim denial, and that's because the payer is saying, we already got the claim, and now you're sending a duplicate. So the key is not to send out a corrected claim until the claim has been considered for payment by the insurer, and it either has to be paid, denied, pended, or something that you received correspondence before you can respond to it. And so you do not want to confuse the computer. And remember, everything is very much computer aided, and they only read it as a duplicate. So you are going to be dealing with contracts and what they say, how they respond to it. But remember, a lot of claims, if you're looking for more money, they're not going to pay you something until they say, okay, if this was a mistake and it's a corrected claim, then we are going to get this money back and then pay it correctly, because they have to make sure they balance their fund. If it's a reconsideration for payment, meaning you don't think they paid you right based on their error, then sometimes they'll come back in and pay the missing amount. But it's really payer driven. So sorry, that couldn't be a little bit, probably more what you were looking for. Okay, so question number 6. I've got a combination code question. It says, Terry, we have a private payer has denied our claim for a level 3 new patient evaluation and management service office visit for missing, incomplete, invalid principal diagnosis. One of our coders says we cannot report M as in Mary 54.16 and M 51.26 on the same claim, but I have never seen anything stating this. Who is right, and how should we have coded this service? Okay, well, first of all, M 51.16, that is intervertebral disc disorder with radiculopathy, lumbar region. That means a patient has radiating pain down their leg. M 51.16 is a combination code. So it describes both problems the patient's experiencing, the displaced disc and the radiculopathy. The M 51.26, that is other intervertebral disc displacement, lumbar region. Because you have a combination code that describes both, there's no need to also report M 51.26. That doesn't even make sense. So when you resubmit the code, make sure that the M 51.16 is the only code that's going to be on the claim. And payers state that you should report the code that best describes the problem. And when a combination code applies, either from a diagnosis or from a procedure perspective, they expect you to submit it instead of multiple codes. And so that's where you could have had a miscoded or denial. And so that would make sense. Number 7, Terry, I'm trying to code a left heart cath, and the physician rarely says he crossed over the aortic valve, and so I'm not sure what else to look for in the report to code the 93458. So how do I code for this? What am I looking for? Okay, so you're looking for something that says LVEDP, okay? So left ventricular, okay, and systolic pressures. So that's important for aortic valve, and it'll show you, it's an important measure of ventricular performance, basically, and may identify patients that at increased risk for developing late clinical systems of heart failure. But you're looking for that acronym, the LVEDP. So again, left ventricular end systolic pressure, meaning that you can't measure that pressure unless you're actually in the heart. So if you have that, or if they say, LV 120/90, whatever they're looking at there, that's what you're looking for within the report. Number 8, Terry, our physician said he did a stress test in the office, but he only injected the patient with a medicine. Is that still considered a stress test? I thought they had to be on a treadmill. So yes, that is considered a stress test. The medicine was probably adenosine or Prasantine or Lexiscan, all which have specific HCPCS codes, which are the medicine codes, to describe how much was used diagnostically. So for an example, if you used 1 milligram of adenosine, your code would be JO153. The procedural code for a stress test performed in the office is 93015, whether it's on a treadmill or by pharmacological induction. And you can see by the 93015 descriptor, it says either or. So it'll say pharmacological induction, treadmill, or bicycle. So Terry, we're having issues with screening colonoscopies. So what is the appropriate modifier when a patient was scheduled for a screening colonoscopy, ends up on the table, and then has a reaction to the anesthesia, so we have to stop the procedure? So for this one, it's modifier 53. And if you are also in an ambulatory surgery center or an ASC, then it would be 74 for you. But in the hospital setting or in the facility setting for the physician, it's 53, and that's discontinued procedure. The 74 is for the ASC, saying that anesthesia was already administered. So that just means you had to stop the procedure, and at some point you may attempt again. But what the 53 also does is you don't run into frequency guidelines, because screening colonoscopies are only allowed a certain time period, so for non-risk, high-risk patients are only allowed once every 10 years. For high-risk patients, every 2 years. So you definitely want that 53 modifier. And then number 10, and this is my last one today, from a Phoenix client, we have a question on a skin procedure. The physician said he did a punch biopsy on a patient, but all I can see in the note is that the patient had an elevated lesion that was rubbing on her waistband and was completely removed by shaving. So how do I code this? I'm not really sure. Okay, so a punch biopsy requires a tool to remove a full thickness cylindrical sample of the skin, and you're doing it for diagnostic pathologic purpose. And those are the codes, they're new actually this year, 11104 to 11105. So, and that's again new for 2019, but it requires that tool, and it's for diagnostic pathologic purpose, means you're taking a sample to see if there's a problem. So that's why they do a punch in a cylinder, in a circle way, so that they can have a specific sample that they can have tested. But what you have here is actually a shave removal. That would be codes 11300 to 11313, depending on total diameter and location. And the fact that the lesion was removed completely, that's suggesting therapeutic intent to relieve the problem. And that's typically more what they're doing there. I actually am going to be teaching a wound care and skin integumentary system webinar in January for ICD-10 Monitor and for ICD-10 University. So check that out on their website. Okay, so we had some really good questions kind of all over the place when it came to the different specialties. And so we just wanted to make sure that we try to hit everything possible. Our Top 10 Tuesday was also brought to you today by Amazon Prime Video Original Series, Tom Clancy's Jack Ryan. In this Amazon Original Series thriller, CIA analyst Ryan is focused on terrorist communication on the global scale. It's in its second season, and you can watch now on Amazon Prime Video today at amazon.com/Prime Video. And Movado Watches, one of the world's leading watchmakers, Movado, modern ahead of its time, Movado.com. I hope this audio is coming across well, and I never actually put that on my podcast, but it's for some reason when I play it back, and I've done a couple edits as I'm recording, I'm finding that I sound a little muffled. If you find that, send me some feedback. I'm just curious. I know my music producer Assassin, he still makes sure that I sound okay, but he's said that I'm kind of going back and forth with my mic, so I'm trying not to do that. So if you find that there's an issue, please let me know and DM me so that I can see what you're hearing on the different platforms. So when I play it back on iTunes in my car as well, I can hear when I've made a little bit of a weird sound or something. But let me know, because I want it to sound clear for you, so you keep listening. So this week, my personal insight has to do with Thanksgiving, and I came across this week a perfect quote, I thought, and here it is. Gratitude is the inward feeling of kindness received. Thankfulness is the natural impulse to express that feeling, and Thanksgiving is the following of that impulse outwardly, and I hope everybody has a happy Thanksgiving. So that's it for me on Terry Tuesday. Make it a great day, a great week, and thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.